Hello and welcome to all. This is Ankana, the assigned moderator from IJCP Group. I wholeheartedly welcome all the delegates across the country. We are fortunate enough to get supported by the doctors. Thank you, all the doctors, for taking out time to join us today. Now, we'll be taking a close look on today's topic, which is successful strategies in hepatitis management. As you all know, that 28th of July, that is tomorrow, is World Hepatitis Day. And now I'm taking this opportunity to welcome the moderator doctor of today's panel discussion, none other than the keynote doctor, Sinha DK Sinha sir. He is the senior nephrologist at Heritage Hospital, Varanasi, and visiting consultant at Galaxy Hospital, Varanasi. Dr. Sinha has various publications, written papers, and they are in his own credit. Now, Dr. Sinha is on into his ongoing project on clinical outcome in acute renal failure in medically and surgically ill patients. He is the life member of Association of Physicians of India, life member of Association of Physicians of India, UP chapter, life member of Indian Society of Nephrology, and also life member of Critical Society of India. Now, without any further delay, sir, I would like to hand over the session to you. Kindly proceed with your topic.
Thank you, Angana. Good evening to all my esteemed panelists and all the audience who are here to attend this uh, talk. We all know that tomorrow is World Hepatitis Day, and we are having three panelists to discuss on the various aspects of successful management of hepatitis. And these three panelists, number one is Dr. Neelam Mohan, HOD and Director, Pediatric Gastroenterology, Hepatology and Liver Transplantation in Vedanta, Gurgaon. She is a recipient of BC Roy National Award of India for her pioneer work. She is also credited with few global first in pediatric liver transplant and first in India to start therapeutic endoscopy in newborn and young children. She is advisor to the National Health Authority of India, Aisman Bharat Pradhan Jan Ayog Yojana. So various good works from Dr. Neelam Mohan. The second panelist is Dr. Raju Singh Chinna. Can I have his credential? Can I have? Yeah. So, no, it's okay, fine. So the third panelist is Vinod Arora, and he's professor, associate professor at Department of Hepatology, Institute of Liver Biliary Science, very esteemed institute, principal investigator in various studies, liver failure. He is a observer at hemodynamic lab, Barcelona, Spain. Dr. Arora has vast experience in management of liver disease patients, post-liver transplant patients, performing endoscopic, colonoscopy, and ERCP, transducer liver biopsy, and all that. He has having many publications to his credit. And the second panelist, as I told you earlier, Dr. Raju Chinna, is Director and HOD of Department of Gastroenterology at Fortis Healthcare, Ludhiana. So he is governing board member of National Board of Examination, member of Institute of AIMS, Deoghar, Government of India, member of Academic Committee AIMS. He is also advisor of UNIDO, it's a United Nations organization. He has been awarded with GS Nani Audition at ISC on 2010 at Kolkata and awarded by Dr. K.L. Vick Foundation in 2014 and 15. He has attended several meetings and activities of his unit of projects and also member of state projects. So there are various facets of Dr. Chinna as well. So these three esteemed panelists, very reputed institution of our country, and we are going to discuss the successful strategy of management of hepatitis. Just brief about the why we do celebrate the World Hepatitis Day on 28th of July every year. This was to raise the global awareness for hepatitis, particularly the hepatitis which is being spread by various means like and basically includes A, B, C, D, and E, and how we can prevent it, how we can diagnose it, and how we can manage it. This hepatitis is killing around 1.3 million people every year all across the world. So earlier in 2008, it was being celebrated in May, and that was promoted by World Health Assembly in 2010. But later on, by the name of Dr. Baruch Samuel Bloomberg, who in fact discovered hepatitis B virus. So in his respect, and on his birthday, it is being celebrated all across the world to raising awareness how to prevent the transmission, especially the prevention of the disease, uh, uh, screening and control of the hepatitis, proper vaccination of different hepatitis, including B and A, and coordinating the global response to the hepatitis. So every year it's having a theme. Last year the theme was one life, one liver, and this year we are having theme of uh, take action, test,
It's time
treat,
to
and
act.
vaccinate. So with this short introduction of this World Hepatitis Day, we will move on to discuss various aspects of management of hepatitis. So we'll uh, I want to listen each one, everyone, brief about the hepatitis and particularly the hepatitis day in brief, and then we'll move forward. So we can start from Dr. Neelam Mohan, ma'am.
Hi. Thank you so much, and I'm so happy and excited to be on this forum today, just a night before the Hepatitis Day. It means a lot to us because we've been connected to liver for decades. Actually, this year the theme is it's time to action because we've been trying to eliminate it with the goal of 2030, but we all know that 300 million still are with hepatitis B and C, and majority of them are diagnosed at a late stage, a minuscule less than 15. So the statistics of 22 suggested like 13.5% who actually get diagnosed initially. Rest of them are all diagnosed pretty late. And as a pediatrician, it's sad to say globally that 45% only received the hepatitis B vaccine within 24 hours of birth. So, knowing that every day 3,500 people die globally every day, knowing that more than 6,000 new infections happen every day, it's time for all of us, besides the global authorities, the government, the doctors, the media, the NGOs, and the community at large, which needs to work together to help us eradicate this. And hepatitis B is a vaccine preventable disease. So we should all aim at a global nation free. I think your mic is on, IJCP. IJCP, madam, can you switch off? Dr. Soap, can you look into that? There's a disturbance.
Ma'am, your video was breaking that time, but it is okay now.
Okay. So that is what I had to say, that it's time all of us need to get together.
Dr. Sinha, you need to unmute the mic.
Yes. So Dr. Raju, can you enlighten us on this hepatitis World Hepatitis Day in brief?
See, it's a very nice thing to be there with all the particular people who look after the disease. I may sound a little pessimistic on the context, but the thing is, the reality is that most of the people in the world do not get the facility of getting well. Most of them are undiagnosed, most of them are underdiagnosed, and most of them are not able to get the treatment. So, what we are probably seeing is the tip of the iceberg. Once we say 300 million people in the world or 30 crore of people in the world, it has to be much more than that. And what we need to basically do is for preventable diseases, infectious disease, I would call the program of KAP, knowledge, attitude, and practices remains paramount. This is the basic SPM community medicine teaching people used to have in villages that people have to normalize of neurosis, they will change their attitude first, then they will change their practices. And this is done, I would say these are baby steps in trying to eradicate a disease which kills almost the same amount of people in the world as tuberculosis does today. So it is high time everybody took it very seriously, and the preventive strategies, to my mind, need to be much more strengthened than the curative intent. Most of the times, our intention has been on cure. Like Aristotle had said, that you can often cure, but you can always prevent. So I think preventive strategies need to be bolstered a little more than we are doing at the present moment.
Thank you, Dr. Chinna. And just a brief introduction of hepatitis, whole hepatitis A from Dr. Vinod Arwal.
Thank you, sir. Thank you for the kind introduction. Dr. Chenna and Dr. Mohan have covered the facts very nicely, sir. So there's very little uh, left to basically say, but we are basically focusing on hepatitis B and C, but with the rise in the non-communicable kind of like the metabolic syndrome, diabetes, prevalence of NAFLD or MAFLD, obesity, the prevalence of NASH, NAFLD, they are also on the rise. There's increased incidence of hepatocellular carcinoma, both in hepatitis B and patient who present with NASH. They usually present with very advanced disease. So the focus should be at screening and prevention, and focus on should be on the universal immunization with hepatitis B, which can be prevented, and screening for the family once a single index case is isolated. The focus should be on that.
Thank
And
you,
there are
Dr.
national
Arora.
program which is
So,
for non-communicable diseases, which is there, which should help in more screening of patient with diabetes and obesity for with NASH and NAFLD, sir.
thank you. So, we are moving forward and we are having a list of questions for each and every panelist one by one. So, I start from Dr. Neelam Mohan. So, how in clinical practice or in our day-to-day practice we suspect patient is having hepatitis? Man,
Yeah, so as we've been highlighting, majority of them, especially in childhood, are going to be asymptomatic. So unless you do screening, you will not know. So it is extremely important that all pregnant women should undergo screening. And when they undergo screening, they will be diagnosed or detected with hepatitis B or C.
thank you, ma'am. Thank you. So, Dr. Raju, can you tell us what are the diagnostic tools that are being used in the clinical practice whenever we suspect the patient is having hepatitis or
So
so?
it is B, then we can give the antiviral. So we can give antiviral to the mother, and subsequently the baby needs to be followed up to check if the baby is positive. Then we treat after 3 years of age, depending on what are the other parameters. But the most important thing to understand is majority of the time they are asymptomatic, and screening them is going to be most important. Children will not present to you with weakness, fatigability, appetite, all these issues which adults come out with.
So, meaning there might, ma'am, one should have a very high index of suspicion, and ideally the patients
And screen
should
all
be screened
pregnant
routinely.
women. So pregnant women screening, screen if other members of the family are positive, then you screen the children too if any one of the parent is positive, and that's how it is presently. So they don't really are symptomatic in young age. However, having said that, some of the adolescents can be symptomatic with the typical symptoms of fatigability, tiredness, jaundice, hepatomegaly, especially if they have had a early transmission from mother to baby.
Thank you, ma'am. Thank you. So next to Dr. Chinna, what are the diagnostic tools which are being used in the clinical practice? Once you are suspecting, or even in the routine practice, you try to investigate. So what are the
See,
diagnostic tools
yeah,
do we have?
there's a lot of background noise. The diagnostic tools are basically once we talk about hepatitis, then we must know that it's not only A, B, C, D hepatitis we are talking about. Though this population is trying to tell us about these 4, 5 types of hepatitis. There are other infections like dengue, leptospirosis, even infectious mononucleosis, and then drugs, alcohol. There are multitude of things which can cause hepatitis. Basically, we divide the diagnostic criteria into two. One is the blood biochemistry and blood virology and blood tests, which would include all the LFTs, viral markers, albumin, platelet, INR, for the various indices of severity of the disease also. And the second is radiology. Radiology, ultrasound, cyto scans, the MRI, look for the various stages of hepatitis and to look for various complications are broadly the parameters which we look for. Dr. Sinha, you are muted.
So you have to keep it on all the time. So there are various type of hepatitis. We are looking various infectious type of hepatitis. Apart from normal hepatitis viruses, there are other viruses, other bacteria also can lead to hepatitis. But apart from that, as very well told by Dr. Vinod Arora also, so there are autoimmune hepatitis, there is alcoholic hepatitis, uh, there are other various types of hepatitis. So Arora, Dr. Arora, can you uh,
Yes, sir.
elaborate the different type of hepatitis?
Sir, hepatitis is just inflammation of liver. Hepatitis, that is inflammation of liver, sir, and it can be because of viral, which can be hepatitis A, E, then the B, C, acute or chronic. Then non-hepatotrophic viruses sometimes can cause inflammation of the liver cell. And then it can be, sir, drug induced. Then alcohol per se can cause. Then because of non-alcoholic fatty liver disease, it can also uh, cause inflammation, but definitely not non-alcoholic steatohepatitis. It can cause NASH. So the hepatitis is just inflammation of liver, which can have a varied presentation. It can range from viral to drugs to alcohol and to unknown causes, sir.
Thank you, Dr. Arora. Ma'am,
Ischemia.
next question to you. Uh, do you have any data regarding the different types of hepatitis, incidence of hepatitis, and prevalence in the society of different types of hepatitis? I'm talking especially for the viral hepatitis.
Yeah, actually, the World Hepatitis Day, when it was coined, and therefore we have a separate World Liver Day. Because, as Aurora said, there is an increase in the fatty liver disease and NASH, etc. But the World Hepatitis Day, we want to focus mainly on infective hepatitis and predominantly hepatitis B and C. And therefore, we will not discuss any further fatty liver disease and other causes of metabolic liver diseases and autoimmune liver diseases, alcohol. Nothing we are going to focus because the Hepatitis Day, this the theme of the WHO is to focus on hepatitis B and C, and we'll limit ourselves to this further. So the incidence, what happens, hepatitis B and C, globally, as I said, the population is still together. It is 3.5% or 5% of the population is still 300 million are supposed to be positive. And thanks to the good cure of hepatitis C, there is a decline in the hepatitis C now. But hepatitis B sadly continues to be more than 300 million. So that is the issue that the statistics are saying that nearly more than 6,000 new infections are occurring every day. And because they are not being diagnosed, and they are being diagnosed in the late stage, only less than 15 are diagnosed, rest are not diagnosed. So that is the main problem, and it is time that we need to understand that if you take a wide survey of people in India, so they also turn out to be close to 5% of the population, if not exact 5, say maybe 4% of the population may be BNC. So that is the what we are trying to focus and trying to say, that if we start screening and diagnosing newborns like Taiwan model. The world has learned from the Taiwan. Taiwan was a country with the highest incidence, more than 10%. And in 1989, they started with the universal hepatitis B vaccination, and not a single infection was escaped. So what happened? Now the population, the overall incidence has decreased because the elderly people who have died and all the new population. So one of the best strategy is to get the universal hepatitis B vaccine. Sadly, our country took quite a lot of time, and it was in early 2000 that we went in for the universal hepatitis B vaccination. But having said that, still all of them do not receive the dose. Less than 50% receive the vaccination within the first 24 hours, and so therefore, the coverage of the vaccine is not in early. And if the mother is positive, then there are two ways. If she is HPS antigen positive but B antigen negative, then only 10% transmission. But along with HBS antigen, if she is E antigen positive, that means the transmission will be close to 90%. So if an adult gets a prick, the chance of Hep B disease is just 5%. But if a child gets it from the mother, then the chances, if the mother is E is positive, is 90%. So our focus has to be on ensuring all deliveries are institutional deliveries, and whether it is in the government or the private. So in India, if since the deliveries are occurring at home level, so that is why the screening is getting missed and the vaccination.
We lost your voice, Dr. Neelam. Thank you. So we move forward. Dr. Raju, uh, can
Yes.
you can you tell us about the different presentation of hepatitis B in the clinical practice or in the society? How you are going to make a diagnosis of hepatitis B infection?
See, before that, I'll lay stress on 2 points. One is, once we talk of hepatitis B and C, no doubt they are important because they lead on to chronic liver disease. But at the same time, in our country, which is a developing country, hepatitis A and E form the majority of the viruses causing hepatitis. So we have to be careful about them also. Hepatitis B basically is a double-stranded DNA virus, and it causes disease in the form of, it can cause acute hepatitis and chronic hepatitis. Acute hepatitis, we all know the typical symptoms of hepatitis are there. The patient will have yellowness of eyes, jaundice, tenderness in the right hypochondrium, things like that. And for chronic hepatitis, we have other signs which can be picked up, and complications of hepatitis B like total hypertension, hepatocellular failure, and hepatic encephalopathy, and things like that. So basically, what is important is that in this on this liver day, prevention needs to be stressed again and again. And to my mind, we are far away from eradicating it. I may sound again a little negative on this. We are far away from it because the ground reality is that it does not reach to people. We don't have a point of care testing, which is very cheap, available to all the people across the country. We just cannot say that we will have doctors might don't agree idealistically that all deliveries have to be institutionalized. How is it possible in a country like India? If you, I go to Devghar All India Institute and I see the plight of people there in the villages. You have to go there into the villages and the tribal belt and then see the facilities what people have. There are almost no facilities. Yes, as a thought, it's Puritan thought, it is very good. But at the same time, what I feel is we must try to have a hybrid model where we are able to take care of the things as and when what are available, and as and when we can go to the extent of having the best care in the world. So hepatitis B can present as acute hepatitis or chronic hepatitis. Dr. Sinha.
Thank you. So, Dr. Vinod, uh, how we can prevent? So we all know that for hepatitis B and C particularly, the route of transmission is basically bloodborne. So, what are various strategies by which we can prevent the transmission of disease from one to another?
Uh, so the prevention of hepatitis B from?
Yes, prevention of hepatitis B and C particularly. Then we will talk
So
about the A and E also.
that basically depends upon the route of transmission. For hepatitis B, the most common the route of transmission will be perinatal from mother to child, and from stopping the cutting of the chain. And as Madam has also already mentioned about the universal screening for hepatitis B in the antenatal population, it will help in reducing the burden of hepatitis B in the children, and cutting of the chain of hepatitis B, almost eliminating the risk of transmission to 0.1% from mother to child, sir. By universally screening for hepatitis B, checking hepatitis B DNA, if we follow the ESA, that is European Association for Study of Liver Diseases recommendation, they basically, if the patient is having DNA at more than 20,000 or more than 20,000 international unit per ml at 28 weeks of pregnancy, and or if the ALT is abnormal, even with the lesser DNA, the patient should be started on TDF, that is tenofovir 300 mg once a day, sir. And the vaccination for child and hepatitis B immunoglobulin, that is universally recommended at the time of delivery, sir, to prevent the transmission of hepatitis B. Hepatitis C transmission is not very common, sir, and the data which is available, there are very few studies for directly acting antiviral in hepatitis C in pregnant lady. They can be tried, but usually it is deferred till the delivery, sir. For hepatitis A and E, the prevention is basically better hygiene, and the mode of transmission is fecal-oral. And for hepatitis A, we have vaccine available. For hepatitis C, not commercially available in India. So it is
We
available, I
will
think,
come
in
on that
Nepal.
topic.
So,
Thank you.
if I may, can I add, please?
Sure, ma'am,
Yeah, man.
please.
Sure.
Yeah, so what I want to say is he's just been focusing on the most. So besides the perinatal, hepatitis B and C, I mean, message for the common public too, spread like HIV. So they are spread through various modalities, infected needles. So you have to be very careful. My message would be do not drug abuse, infected needles, dialysis, dental procedures, ear piercing, barber shop, shaving, nail filing. Wherever you can get it, you should not expose yourself. Ensure that all this Even if you change the blade in the razor, even in the dried blood spot of the razor, the virus can live
Hepatitis
for
B.
1 week. So that is
Uh,
why you can get the infection, and unprotected sex can give rise to infection. If a person is injured, use a hanky or a cloth before you touch the open wound so that you can protect yourself. So, these are the messages that should be given. Any blood transfusion should be ideally NBT, which means we should check not only for the antibody antigen, we should test the PCR technique for the virus so that the risk of transmission is minuscule to negligible. So, these are the various ways of preventing hepatitis B and C transmission.
So do
Basically,
you
we are
feel
screening for hepatitis B and C only, sir. Surface antigen anti-SCV can be checked, and anti-occult for occult hepatitis B, anti-co total, anti-HB co total should be checked for occult hepatitis B. So, ma'am has already mentioned various mode of transmission and how to prevent them. So, that basically
so in
answers the
society
question.
usually what happens, the most of the hepatitis, particularly B or C, are basically chronic carrier we are getting in day-to-day practice.
It is more of chronic, sir, rather than acute.
Yes. So like hepatitis C is having mostly a chronic presentation. Hepatitis may have a initially acute presentation and later on, but what we see that many patients are being diagnosed at the time of some screening or sort of thing. So what are the simple things a physician or a practitioner should do to make a diagnosis of hepatitis B or C? Dr. Raju, you can answer on this question.
I think Dr. Neelam has very aptly raised the concerns about hepatitis B spread, especially in IV drug abusers, barbers, and even these beauticians. Many of the ladies are finding them very, I would say, very important to visit these days. But the important message which should be going is that we should not be avoiding sharing personal items, whether it's a toothbrush, whether it's a razor, whether it's any of the equipment used in the barbers or in the salon shops. Tattooing, piercing, ear piercing is another one. Blood testing remains important. The symptoms are basically for all hepatitis almost similar, Dr. Sinha. For hepatitis B and C, because most of the presentations are chronic, very little of hepatitis B and C is acute.
You are mute, Dr. Raju.
Very few of patients of acute hepatitis happen with B and C. So it is basically the chronicity of the disease which should be picked up. Picking it up clinically is important. Then picking it up on a radiological examination or on a blood examination is important. Symptomatically, if the patient is losing his appetite, having a dark colored urine, having jaundice, having loss of appetite and malaise. And the most important thing is people who are at high risk. High risk people are the people who are IV drug abusers. High risk people are the people who have unsafe sexual practices. High risk people are, I would say, all the healthcare workers because the way we carry on we have a hospital injection control practice that you must always cap the needle with one hand. I have not seen many people doing that in daily practice. So it's on paper, but it doesn't go down to reality so much. So needle piercing in the hospitals is also a very common cause of spreading this infection. Though in a hospital, because it is reported, we are able to take care of it much more in a much better way. But just think about all the dyes in the periphery, all the RMPs in the periphery, all the people who are getting injections in the periphery. So it is a mammoth problem. And the mammoth problem does not stop only with using infected needles. The mammoth problem is using reusable needles which are reused. There is a whole bracket going on this issue also. That is a separate thing, but we have to be careful about all. Hepatitis B per se, I have already told you the symptoms are not, there is no specific symptom, there is a general symptoms of hepatitis that you can have with that.
So, Dr. Vinod, I was asking what are the simple tests a physician is supposed to do when he or she is suspecting that patient might have hepatitis B or C infection? Like, what are the various serological and virological markers which can be done in the clinical practice? EGD, not the hi-fi, not a very expensive test,
Sir,
but
hi, I
simple
just
screening test.
uh, so for hepatitis B, we'll have HbA sir, that is the surface antigen, and for basically seeing the immunity to hepatitis B, so antibody to the surface antigen, that is anti-HbS, and sometimes they can be surface antigen mutants, so anti-HB core totals. These are the basic three investigation which should be done for the screening of hepatitis B, sir. For hepatitis C, that's anti-HCV, and for hepatitis A and E, we'll have to basically, if we are suspecting acute, then we'll have to either see for IgM Hep A and IgM hepatitis E, sir.
So there is any difference between just a kit test from any kit, or now nowadays people are doing titer also of these antibodies and these antigens. So
Uh,
which
uh,
is supposed to be more specific.
we basically the quantitative HbA can be used as a guide for the antiviral treatment, sir. But usually it is the qualitative which we use commonly, sir. Quantitative usually we don't use it as a screening tool, sir, for hepatitis B. If surface antigen is positive, we'll definitely have to check for hepatitis B DNA quantitative, sir, and the ALT value and the replicative markers, that is HBE, AG, and anti-HBE, sir.
Thank you. Dr. Neelam, I want to just know that you know the hepatitis C is also having some extra hepatic presentation as well. So can you enlighten us on this aspect? Because hepatitis C might have other presentation also apart from hepatitis.
So, uh, sorry, I think there is little instability of the connection. So
Can,
basically,
can I repeat?
you
Can I
can
repeat
have
the question?
manifestations uh, like the skin lesions, cryoglobulinemia, etc. But I generally take my suggestion would be that in the all doctors, whenever you get an opportunity, you must look for HBS antigen with the slightest concern that you have. Like, you would be seeing diabetes, kidney patients, chronic patients, not driving, overweight, underweight, cardiac. So it's such a simple and a non-expensive test which is available everywhere, a card test in everywhere. So I think with the population and the number of percentage that we have, if you have 3%, one in 3 out of 100, so it is absolutely okay to do, and therefore it is a protocol in all corporate and government hospitals before any procedure where they will do an HBS antigen, an HCV antibody, and an HIV. And I think this is totally justified to do a screening in the slightest of doubt that you have in any procedure. That is number one. And for the healthcare professionals, including all of you sitting here and me, do you annually check your HBS antibody? None of us check our HBS antibody. It is extremely important for high risk people, chronic liver disease, fatty liver disease, alcoholic, chronic renal disease, cardiac, diabetes, and healthcare professionals. We all need to be especially healthcare professionals. We should keep our HBS antibody at a higher level. We like 100 and not just 10 for a common man. So we should also be vigilant. We should also get our antibody. And the message to everybody listening is, if you're not sure that you've received the hepatitis B vaccine, we are not telling you that this vaccine is only for a newborn. No, this vaccine could be taken by both newborn children, adults, elderly, everyone. So the dose is zero point 0.5 ml for children and 1 ml for adult. Simple, cheap vaccine. There are good. So this vaccine can be taken by everyone to protect themselves from hepatitis B. That is the key message. If we can draw out of this discussion, I'll be happy. And all of you, in women who go for pedicure, manicure, and this thing, and men who go for, carry not only your own sterilizing solution, because the virus can be killed if you put it in the sterilizing solution. So that is extremely important and message I want to give. And I'm happy to say that I was the first one 20 years back who approached VLCC Vandana Luthra, and I made it mandatory that all the combs, the filers, everything is put in a sterilizing solution between patients, or now you see them using that. So these are the common things we can do to there. And always remember, these infections can be anybody. It's not necessarily, when we are saying 3%, why me? It is more than one. So in a given hall, at so many times you see more than 100 people in a hall, so many in the school. So doing screening is the way forward, and universal mass vaccination is the way forward. And other message which I want to draw is that usually we say hepatitis B immunoglobulin should be given for a baby who is born to a hepatitis B positive mother within 24 hours. But if you missed it, you can give up to 7 days. You can give that and use it. This thing. So the cure for hepatitis C is so cheap now in India that every opportunity, a patient where you're suspecting liver issue, they should all have its hepatitis C screening by a simple test, HCV antibody, and then if treated by referring to any liver expert or a gastroenterologist, they can be done. And so that's my message, that we should be doing camps for such screening and antibody vaccination, which you don't see nowadays.
Just to adding to your this statement, ma'am. See, in clinical practice, being an nephrologist, we also vaccinate for most of the patients, but sometimes we do not see the response from the patient side, because the patient's GFR is towards the lower side. So, can you tell us how we can improve this
Yeah, so
immune response?
right. I would say that the vaccine is 98%, but you're absolutely right. There are some individuals, especially dialysis patients, being a nephrologist, where you are stuck. So, some people, I will also allow Aurora to answer, but some experts believe in two things. One is you can double the dose and see in them, number
That we
one.
do. That we do. That we do.
Number two, there was some research which the Singapore team had worked with, and they tried using that vaccine, which was not easily available for commercial use. Dr. Arora, can I have your opinion on the patients, the 2% who do not respond to hepatitis B vaccine? What would be your approach?
Repeating the schedule for them, and maybe giving instead of 20 microgram, giving them 40 microgram.
I've already said
Not
that double dose. I want to
Yes,
know
ma'am.
about
Yes.
the newer vaccines which are on the block.
Maybe they are based on the RNA, hepatitis B RNA, but I don't think there are any commercially availability of these vaccine as of now,
That is
ma'am.
the problem. So that's what, as I said, so nothing new. I thought in case I missed on. So
No, ma'am. No,
basically,
ma'am.
we give double the dose, and even in children, we give double the dose. As I do liver transplants, I see sometimes they don't have, but I regularly check yearly in them and give them double the dose, and I do see response with that. Or give them a second 3 doses and see response with that.
Maybe a booster with hepatitis B immunoglobulin.
And non-commercial for doctors and all. So there are new vaccines which do not work through surface. That is the vaccine they are trying to work on, but commercially still, I'm not aware whether it's got approval or
Basically,
available.
the vaccine they are basically on CCC, the DNA, or basically on hepatitis B RNA in the.
I
Uh,
remember the
can I,
CCC
can I,
DNA, but
can I come in?
that's it. So
Dr. Sinha, I'd just like to make a comment on the dialysis thing because we have a lot of patients with who require this vaccination at our center. Uh, there are two, three things which are important. Number one, for adults, normally we do 016. For
Yeah.
these people, we do a four doses, 0, 1,
Yes,
2, and 6.
additional 0126.
One
Yes.
thing which many of the researchers have found is to give a better response is give half the dose on one deltoid and half the dose on the other deltoid. And even if after that you have problems getting an anti-HPS response, it's basically the body's response to the vaccine rather than anything else. So that would be a very little percentage of people. And I don't think so at the present moment we have any clear-cut guidelines on that.
Just one question for all of you. Why we don't have any vaccine for hepatitis C? Is there any possibility
uh,
to get a vaccine for hepatitis C?
yeah, can I answer that?
Yes, sure.
I'll see what Aurora and others have to say. I see. See, the world was working on hepatitis C vaccines, and they were all in phase 3 trials, and great work was being done. And then suddenly you get a cure with a magic drug. So when the cure comes on the magic drug, which then automatically the funds that were being used in the vaccination, I think, got tremendously reduced. So the objective was changed because the vaccines that they were working was not only the prophylactic, but they were working also on the therapeutic vaccines. And then all this, the new drug, the magic drug came, and now with the use of a combination of a drug that virtually 100, they say, you know, you can get rid of it within 12 weeks unless you're a cirrhotic, then they would want to give you for 6 months. So I think that was the reason for that. And that gives me an opportunity to also tell you all that the amount of money that is spread, donation for HIV, is 10 times more than hepatitis B. And that's the problem. It's time that the globe realizes that hepatitis B is a major threat and it spreads much more than HIV, and the funds have to be allocated on this. So it's right now we get only 1/10 of what we get for HIV.
Thank you, ma'am. Thank you. So, just a little bit about the management of hepatitis B and hepatitis C in both setting, in acute hepatitis setting and in the chronic hepatitis setting. So, Dr. China, can you enlighten us on this aspect? Management of hepatitis B in acute setting and in chronic setting. Management of hepatitis C in acute and chronic setting.
See, most of the times, once you have a acute setting, we generally will not go on to be very, very aggressive as far as the antivirals are concerned, unless there is a liver failure, unless there is a coagulopathy, unless the patient is going downhill, and patient is lined up for a liver transplant with Dr. Mohan. So these are the indications in acute where you like to treat. Otherwise, generally most of the time in acute hepatitis we follow a conservative approach. As far as the management in chronic hepatitis is concerned, it is a long process, but I'll cut the story short. And for the available listeners, for hepatitis B, we have basically TAF, we have Entecavir, and we have Adenovir. So basically, these are the three drugs. Out of these, the cost of most of them is about ranges from 1,000 to 1,500 rupees for 30 capsules, and you have to give one capsule a day. So you can choose any of them. The important thing is CAP is used very commonly, and Entecavir is used wherever you are thinking of resistance, zero point 0.5 to to 1 milligram. As far as hepatitis C is concerned, very simply, for hepatitis C, we have for hepatitis B. Another thing which I like to bring to the for the audience is that there is a government of India guidelines on it also. See, there are one which we commonly hear is that the American Association guidelines, the European Association guidelines. There are government of India guidelines also on the management of hepatitis B, and they take into consideration only hepatitis B surface antigen and HPV DNA. The E antigen is not in the picture, though E antigen comes into picture whenever you go to an institution. So one is this. The for hepatitis C, uh, the treatment is very simple for all practical purposes. 95% of the times, a combination of sofosbuvir and velpatasvir once OD for 12 weeks is good enough in patients who are do not have cirrhosis or have a compensated cirrhosis. People who have decompensated cirrhosis, you may add ribavirin or extend the treatment for 6 months. Now, ribavirin has got many of its fallacies in terms of hemolysis and things like that, anemia, it should not be given, and there are certain drug interactions where it should not be given. So it becomes basically that. The problem is that most of the people in North India, we have a very high incidence of genotype 3. Now, once you have genotype 3, then the span genotypic drugs are okay unless we have a mutant. So, once you have a mutant there, then the problem arises, and for that, we have to do the mutation studies, which is fortunately the percentage is very less. So, basically, to cut the long story short, three drugs, any one of them, depending upon you guys. These are safe drugs for even dialysis patients. And then this is it. There are newer drugs available. They are coming up. And in due course of time, you'll have many drugs. But the important thing to me is that it is high time we are able to generate one test which picks up the virus multiplication in addition to its presence. What I'm trying to say is we have to have a single test which says कि hepatitis है or hepatitis कितना है. And then the treatment protocols will become easier for the general population. Hospitals, it is always easy. You have algorithms, you have the AI now, and you have very well read people who have gone through so much of literature and their own experiences also. So that is not a problem. The problem, to my mind, is at the periphery. The problem, to my mind, is the people who have no access. The problem, to my mind, is how to make it simplified, how to make it easily available, how to get the vaccination done for as much of a population as it possible in the country. So this is a very big Herculean task, and we must all put our efforts together for it. Obviously, HIV, there was a lot of love created about HIV, and obviously, mentioning that is come out. I'm sure all the people talking about hepatitis B, C at all forums, whether it is the media, the government, or even at private institutions like colleges and schools, the incidence is common.
Thank you. Dr. Vinod, my my another question that very you can say when to treat the hepatitis B patient because what I saw in the literature there are a lot of things. It is not a very simplified approach. Can you make it simple for all of us that when to treat hepatitis B positive patients with all these available antiviral drugs?
Sir, I'll try to simplify it, sir. First, we should see whether there is cirrhosis or no cirrhosis, sir. Whether we are suspecting the fibroscan may not be available in periphery, sir, and the burden of the disease is periphery is maybe higher than the urban part of India. So maybe platelets, INR, they can be used to see whether, just to assess the severity of fibrosis, LFTs, albumin, platelet, they should be readily available. If the patient is having cirrhosis, start on antiviral with the surface antigen positive, whether it is TAF or entecavir, sir. For sir, if the labs are available, sir, if fibroscan is available, then the liver stiffness measurement, if possible, then it should be done. And depending whether the patient is having cirrhosis or no cirrhosis, the treatment should be defined, sir. As of now, we have defined guidelines from the APASL side, that is the Asian Pacific guidelines, sir, from the INASL, that is in Indian National Association for Liver, whether the patient is HBE positive, HBE negative, and how is the ALT and how the what is the DNA level and what is the replicative status of the patient, whether it is E positive or E negative, sir. Depending upon what is the DNA, whether it is more than 2,000 or 20,000 E positive or E negative, respectively, whether patient is having abnormal ALTs, that is kind of 29 and 19 in male and female, respectively, sir. So we can decide whether to start antiviral. However, to simplify it, sir, if you're suspecting cirrhosis, even if the fibroscan is not available, if the there is a family history of cirrhosis or liver cancer, uh, should start antiviral for hepatitis B, sir. If we measure the risk benefit, the benefit is more as compared to the risk. For hepatitis C, we have to see hepatitis, the RNA, anti-SCV cannot treat, sir. So SCV RNA is a expensive test for Indian masses, definitely. So NT-SCV is a screening tool. Anti-SCV RNA quantitative will guide whether we'll have to start antiviral for hepatitis C or no, sir.
Thank you. So my next question goes to Dr. Neelam. Ma'am, just we are already coming to the last stage of our discussion. I want to know from your side, from you, that how we can manage the chronic complication of hepatitis, like uh, this portal hypertension, GI bleed, ascites, even hypersplenism. Right now, I'm having one patient. We are unable to improve her platelet. So can you let us know this
So,
aspect because
simple things, I will make it very simple and not complicated. First thing is, if hepatitis B, if they get into cirrhosis and decompensation, nothing else except a liver transplant. Even if there is developing a cancer like state, then before that spreads, you should be detecting both in B and C for HCC, because we know that B can bypass cirrhosis and cause malignancy. At least C behaves itself and goes through cirrhosis and gets into cancer. So, in that case, liver transplant is the answer. And because hepatitis C management is available even for cirrhotics, now the incidence for hepatitis C liver transplant indication is reducing. People are trying to give even the cirrhotics antiviral and see the response. But the decompensated patients go in for transplant, because if there is no reserve, what will you do? You can only prevent further damage, but you can't change the reserve. And similarly, hepatitis B, if they are cirrhotic and decompensated or malignancy, they have to go for transplant. Transplant is now available pan India, and a lot of centers government is also trying to, do it. So that is the answer. And there are a lot of factors which need to be looked. What is the age? What are the comorbidities? Cardiac comorbidities, diabetic comorbidities, malignancies, age, the family, the background, the cost, renal issues, everything has to be put into account when you decide for this. And for children, the life is still better. What we have is simple antiviral therapy. But what is very sad is we don't have a definitive answer when to stop it. Because what does the bee do? Bee goes into your liver cells, and the liver does not realize that it is an outsider. It just puts itself into the DNA and makes it a friend, and therefore it is always in your liver cell. So, therefore, most of the drugs that we are using presently are only to inhibit replication, and therefore it is not a finite therapy, and we are using indefinite antivirals for a longer time. And even in children, they say, okay, use 3 years, stop and see. There is relapse. That's all for experts. But mota, antiviral in hepatitis B are just reducing the replication and need to be used for a longer time. And antiviral in Hep C are short and definitive. They kill the virus, and therefore it's a definite therapy and it's a short therapy. So that's the way I just can say. If you've lost, there is a statement, there is a movie which says, if you can't change the girl, change the girl.
Thank you. Uh,
If you can't change the liver, change the liver. So, my
just
message
one
to
more
all
query from
doctors who are
LinkedIn to
there
you.
is
Ma'am,
one message to
one.
all doctors to
Thank you.
please get your antibody level checked. Keep it above 100. If it is less than 100, your HBS antibody, go and get yourself vaccinated. Meet or connect any one of us will tell. So, that's my message for the doctors.
Thank you. Can you just uh, briefly tell us about the how we can manage the hypersplenism in a CLD patient?
How can we manage?
Hypersplenism.
Oh, okay. So, very simple. Hypersplenism, most of it we get very excited with the low platelets and all. Now, you have to realize that, like we see hypersplenism in extrahepatic portal vein obstruction too, EHPVO, where the liver is not damaged. So, if there is hypersplenism and the it says that there is portal hypertension, eventually, if you are able to prevent the further progress, if it is hep c and all, you can do. But otherwise, hypersplenism, which is secondary to cirrhosis and not a EHPVO, because EHPVO patients also get blood transfusion and they can have hepatitis BC positive. So you have to be very sure that this hypersplenism is not due to EHPVO, not due to thrombus, but due to cirrhosis of the liver. And in that case, don't get scared with the platelets. Look overall the synthetic function and all, and then decide for the time of transplant. Because even with the low platelets, it's not that immediately I need a transplant for that.
Thank you,
You
ma'am.
have to look at it holistically.
Agreed. Agreed. So I think last question to Dr. Raju. Just tell us briefly about the how we can decide the severity of chronic liver disease and what are the indication of liver transplant. Uh, uh,
Basically,
what
there are
those kind of
basically,
diagnosis, Dr. Arora?
I would say that clinically, the severity comes once you have a failure. Once you have a coagulopathy, you have a liver failure, you have a hepatic encephalopathy or a renal failure or a hepatorenal, the patient is in a bad condition, irrespective of the scores. There are various scores available. There is a MERT score available. There is a price criteria and all those things which you can keep on calculating by even down to for a computerized, computer-based algorithm related to therapy. But in broadly, whenever you have any of these things, coagulopathy, hepatic encephalopathy, hepatorenal, you are dealing with a bad situation in cirrhosis. And these are the areas where we have to be really careful about. And basically, once you will calculate their scores, the MELD would be more than 20, the CTP would be more than 7, 8. So that is for the general practitioners, that if we have any of these things, we should be doing this. What was the other question, Dr. Sinha? One was severity. You asked me something else also.
And then indication of renal, the liver transplant.
See, indications for liver transplant. There is a lot of indications for liver transplant in present scenario, and it is, if you ask me, for all practical purposes, for end stage liver disease, whatever may be the cause, whether it is a Hep C related thing or a Hep B related thing or related to alcohol or anything else. This is the only definitive treatment available. The rest of the treatments are buying time. You are bridging towards a liver transplant. So if liver transplant facility is available, then the patient should be offered. The problem in our country is we are a country where people are not disease conscious, they are death conscious. They run once they think they are not going to live. So that is the problem. That is why liver transplants, most of them would be coming at a very late stage. If you ask a child's A, where you have the best outcome to get a liver transplant, they will just look at you and see and smile and think that this doctor is out of his mind or something. But people need to be educated on this. So liver transplant is the need of the hour, and liver transplant in our country, Neelam knows they are one of the biggest centers for transplant in the country. There is so many people are waiting, dying for a liver transplant, and one is waiting, they do not get a liver transplant. The second is the cost, the economics. It is not easy to get a liver transplant for an average man in our country. So these two things are very important. So the importance of prevention is better than cure. I say prevention is the only cure. And at least in the developing countries where we are placed very low in our per capita GDP, if you look up the figures, then it becomes the out of pocket expenses for healthcare are close to 70%. 70% of our people pay their hospital bills out of their pockets. So this is a very big number. The insurances have to come in. The government has to chip in. A lot of things have to be done, and it is a big problem. It is not a small problem, but I'm very sure in coming days, with the knowledge and the awareness being spread about hepatitis A, about hepatitis, this is one of a very small thing which we are doing, trying to spread awareness about it. But every small pebble in the sea counts, and this is how I look at it. And very soon, I'm very sure that we'll be able to take care of this problem, the scourge of hepatitis, and we'll eradicate from our country like we have eradicated polio.
Thank you. Thank you. So we all have very nice interaction and very informative discussion. Uh, Dr. Neelam, Dr. Raju, Dr. Arora, thanks a lot, and thanks organizer for giving us this opportunity on talk on this very important occasion, World Hepatitis Day. And with this, we
And
conclude our
a very,
session.
very special thanks to Dr. D.K. Sinha that in spite of being a nephrologist, he agreed to be a moderator for a very important topic
Thank
for
you.
a gastroenterologist. So I think you deserve a special clap and a special salute for that.
Thank you,
And
ma'am.
Dr.
Thank you.
Neelam is traveling. I still believe she is traveling.
Dr. Sinha, you were such brilliant moderation. Thank you so much for
Thank you,
this.
ma'am. Thank you.
And I look forward to see you in person, Dr.
Some,
Raju.
some.
Love to see you
Anytime.
in
Welcome,
person.
welcome to sit
And it was
Varanasi.
so
Yeah.
nice to meet Dr. Raju, who's a very practical person, and I've known him for decades. And Arora ji, I think I can't see. And he was also very bright and
Thank you,
nice.
ma'am. Thank you. So,
So I think
organizers,
the key
please.
messages from the are just to Raju said prevention, prevention, prevention. So,
Agreed.
like hepatitis B spreads like HIV, no unprotected sex, the screening regularly for HBS. Be careful for your ear piercing, nose piercing, pedicure, manicure, barber shop. All this, be careful. Be very careful. Ask for safe injections. Be careful when you go to a kidney specialist for dialysis. Be careful when you go to a dentist and demand. So these are all the places where, and safe blood transfusion. If you have an exposure and need any accident or anything, use a hanky over the wound of the person whom you are protecting in case you have a cut on your hand, so that could go in. So this is all prevention. All pregnant women should get themselves screened. If positive, they should treat themselves in last trimester and tell the doctor to give vaccine and immunoglobulin. All contain vaccine at all ages. And healthcare professionals should maintain their antibody titer, and that's the prevention. And for cure,
Thank you.
go to a gastroenterologist, liver specialist, who will guide you further for the treatment.
Thank you, ma'am. And I think thanks again, once again, to all of you, and thanks organizer for giving us this opportunity. So have a great time.
Thank you, Sena.
Thank you.
Thank you.
Ankana, can you
Oh,
conclude?
Raju,
Yes, thank you so much. Thank you, Dr. Sinha sir, Dr. Chinna sir, and Nilam ma'am, for all of
I
your
apologize
insightful
for the
talk.
poor internet.
Thank
Due
you.
to
Bye bye.
jam, my car got stuck and
You're
I reached here.
traveling, ma'am, not an issue. You're traveling because that's why. And being, as Dr. Chinna sir has said, being a nephrologist, Dr. Sinha sir has completely just moderated the session so nicely. So thank you.
Thank you.
Thank you all the doctors for your expert opinion
Thank you,
that you have shared.
IJCP, for this
Bye bye. Bye
opportunity.
bye.
And I would also like to thank all the participating doctors for your continuous participation at our platform. Thank you once again, all the doctors, for your valuable time and for being with us at our platform and sharing such valuable insights with us. So, with all your permission, can we just end the live here?
Yes, please. Yes.
Thank you, ma'am. Thank you so much.